Hello and welcome to the Interventional Octagon. Today we're going to talk about the coronary CT-guided percutaneous coronary intervention, a great area that is developing rapidly and is becoming very relevant for the day-to-day practice with a lot of applications and increasing use across the board. We have a tremendous faculty, Dr. Ziad Ali from St. Francis Hospital in New York and Dr. Farouc Jaffer from Mass General. Both are experts in this and have been working on CT-guided PCI for many, many years. We do have 4 finalists, Dr. Mohammed Alam, Dr. Mesita Goel, Dr. Ahmad Samir, and Dr. Nick Williford, who will present their cases. Each case and discussion will be about 15 minutes to give everyone the time to present their case, and then the winner will win a $500 Amazon certificate. This is the disclosures for the family, and this is for accreditation. There is CME accreditation for this webinar. You can get it by going to the CVI website and requesting it. And many thanks to the sponsors of this activity, which is Abbott, Boston, Cordis, and Medtronic. And also to remind everyone, CVI is coming August 6 to 8, 2026, and would love to see everyone in CVI. Also send your cases, the case competition in open, send your abstracts, would love to see you there. So without further ado, we'll start first with Dr. Alam. Dr. Alam, looking forward to seeing your case. All right, Dr. Alam, looking forward to your case. And again, this is very interactive, so any questions that come from the faculty or the other participants, that would be great.
Good evening, everyone. It was a great pleasure to be with you at this meeting. Our case today was about multi-slice CT coronaries. Is it maybe misleading? We have no disclosures. Our case was about male patient 63 years old, hypertensive with a history of coronary artery bypass grafting 6 years ago. Our patient complained of typical chest pain, Canadian class 3, which improved mildly with medical treatment to be Canadian class 2. There is no specific ECG changes, and the echo shows concentric VH with good ejection fraction and diastolic dysfunction. We perform multi-slice CT coronary angiography to the patient. Actually, I'm sorry, I have no images for it, but I have the report because it's about of 3 years ago. The multi-slice CT shows the left main bifurcates into LED and LCX without lesions. The LED got caliber with proximal significant lesions. The LCX gives 2 OM branches with patent grafts. The RCA with patent graft, and the lima shows distally totally occluded at the anastomotic site. This is the report of CT. So we perform a coronary angiography to the patient, which shows the distal significant lesion in the left main and the mid-segment significant lesion in the LED. There is also shadow of 2 OM branches, and the RCA distally have a significant lesion, and the grafts to OM branches are patent, and the graft of RCA is patent. And this is the lima. What do you think about this lima? It's mostly occluded. So our recommendation was to perform a PCI to left main LED with 2 overlapping stents. But is it possible that we have another opinion? We think about the patient complaints. It was mild and improved with medications. Can we think about spasm? So inject multiple nitrate infusions. The lima was opened and the LED was opened. But there is a moderate plaque at the anastomotic site. After nitrate infusion, the lima was opened and there is a moderate plaque at the ostium and the anastomotic site. So we decided to perform an IFR to the Lima.
Okay, and maybe we can take you to talk for a second there. So, Farouc and Ziad, I know that this is obviously something not very common doing interventions in the Lima. How often do you do physiology in the Lima? Is that something that you often do? Now, and then, yeah, maybe that will start with that question.
Ziad, want to go ahead? Or
Yeah, or Farouc or Ziad, whoever wants to.
sure. I think it definitely is something that does get done for grafts. I think we all pause because when there are two sources of flow from the native and the graft, there can be basically an undersensitivity for ischemia. So I think we're happy to consider that if the result is positive, but also very importantly, as in this case, ensuring that there's not spasm as one touches touchdowns and goes through kind of tortuous segments. This is a very interesting case, and Dr. Alam, do you know if the original CT scan was performed with kind of classic protocols where nitrates are usually given to patients before the CT is performed? Do you have that detail?
They didn't give a trade before CT.
They did not. Okay. Interesting. I usually think of it for just general vessel caliber, but in this case, it might have been really instructive regarding spasm.
Yeah, and that's a great point you bring, Farouc. I mean, Ziad, I know you have a very busy CT lab. How much nitro do you give to the patients before doing the coronary CT?
We actually try to give 800. So we have a very aggressive protocol for vasodilation because obviously the bigger the artery, the clearer the picture, as long as the patient can tolerate. But if we can't give 800, we try to do a minimum of 400. We noticed that we don't give liberal nitrates, the quality of the scans is significantly deteriorated.
Wonderful. So I guess maybe part of the reason that the Lima here did not seem occluded on the CT might have been the lack of nitrates, which is exactly, Dr. Alam, thanks to you, that you suspected that you gave the nitrates, so it could all be just an artifact from spasm, underlying spasm from the Lima. But maybe you can go on with the case. So what did you end up doing for this patient?
We perform an IFR to the anastomotic site lesion multiple times. It was non-significant lesion. So the final plan was changed. We recommend maximizing medical treatment to the patient with a therapeutic dose of nitrates. Till now, the patient have no complaints after 3 years with 2 non-invasive functional assessment with negative results for ischemia. So the final plan was changed. Our take-home messages: the first impression is not necessarily the last. The patient complaints are the cornerstone for the management. Dealing with coronaries required a combination of non-invasive and invasive modalities. And thank you.
Wonderful. Yeah, thanks, Orlam. Again, very excellent presentation, and reminds us that sometimes the best intervention is the one that's not done. Farouc, any other thoughts on this? Anything that could have been done different? Would you also have not studied? I mean, on angiography, I must admit, the distal anastomosis looked fairly tight, but the physiology was negative. And at least in our lab, we often do physiology if there is a side branch of the Lima, you're concerned for steel, to see if this is indeed the case or not. But here, there was not a major side branch. But would you have done the pressure? Would you have stented this Lima? What would you have done if it was your patient?
Yeah, I think this is an incredibly important clinical observation to have considered spasm at that point, because that isn't always routinely done. But fortunately for those who are physiology and imaging oriented, they're going to give nitrates intracoronary down the graft or native vessel. So that might have revealed itself during that process, even though one was thinking about an intervention. If I had to do this, so I felt like spasm was not the issue and people were medically optimized, my primary choice here would be DCB at the touchdown. I would do as my initial step, especially if it's early on after bypass because of intimal hyperplasia responsiveness. I would absolutely want to avoid stenting from the Lima into the native, because if that's occluding, then it can be very hard to fix the native to follow. So DCB would usually be my preference at this point.
Perfect. Ziad, any thoughts? I think you're muted. Sorry, Ziad, I think you're muted.
Sorry, Manos. So, of course, one of the things that you have to be, I think you mentioned, is that if you're, you have to pay attention to the caveats of doing pressure wire assessment through the lima. One, of course, is the tortuosity of the lima, which can create a coat hanger effect, right? So you get a pressure difference across the lima because of the tortuosity of the lima. So that coat hanger effect can give you a falsely positive FFR. In this case, you didn't have that, which was very useful, but that's a very important caveat. Again, I mean, to me as well, this looked fairly tight, and I think I would have probably used the oculostenotic reflex and done some sort of treatment. So it goes to show that using physiology in these situations can be very helpful. And sometimes doing the least is probably the best for the patient.
Yeah, absolutely. And another way to get around what you just mentioned, Ziad, the accordioning effect of the wire into the lima, in this case, because you did have flow from the competitive flow from the native, you could put the pressure wire through the native, and this way you get still the distal pressure to the LAD without having the issue of straightening out the lima. But again, great point and great technical tip. Wonderful, perfect. Well, if Dr. Alam, thanks again. That was an excellent presentation. And then we'll move on to the second presentation. If we can maybe stop sharing, and we'll have Dr. Guel present her case. So Mishita, please go ahead.
Okay, good evening, everyone. I'm Mishita Goyal. I'm one of the interventional cardiology fellows at Minneapolis Heart Institute, Hennepin Healthcare. And this is my case of a CT-guided PCI. I have no disclosures. So this is a case of a 79-year-old male. He has a history of hypertension, hyperlipidemia, known coronary artery disease with history of RCA PCI that was done 10 years ago. He had been complaining of progressive exertional chest discomfort for 3 to 4 weeks. And for that reason, he ended up getting a coronary CTA. He was already on baby aspirin, atorvastatin 40 and Imdur 30, could not be on beta blockers or calcium channel blockers due to bradycardia. So he came to us with this coronary CTA report where he had gotten 800 micrograms of nitro prior to the CTA, but no beta blockers were given because he was bradycardic. He did have atherosclerosis in all his coronaries, but the most significant was over 70% proximal LAD stenosis with 50 to 69% first diagnosed stenosis that was mentioned in the report. And we reviewed his CTA. These are his MIP images where we can see that he has a stent in the RCA, which appears to be patent. He does have mild disease in his prox RCA as well. His left main also, there is some calcification, mild disease. His LAD is diffusely diseased, as can be seen here, moderate to severely diseased, involving the diag ostia with mild soft plaque as well. The calcification can be seen at the ostia of the circumflex as well, and this appears to be an eccentric calcium. So these are the axial images where we measured his aortic root to be 33.3 millimeters at the origin of the left main, and both his left coronary system and right coronary system appear to be arising from left coronary cusp and right coronary cusp respectively. This is his MPR image where this is the straight MPR, which is pretty much like an IVS pullback, where this is the healthy zone that I had chosen proximally, where I did not see any disease. So involving the left main, and the distal landing zone that we planned was in mid LAD, past this diagonal branch. And this would be our healthy to healthy segments. And the distal reference diameter was measured to be 2.0, and the proximal was 3.5 by 4.0 here. Now, this is the interactive plaque AI-QCPA analysis, where if you see the pullback from ostia left main, here the yellow is the soft plaque, and there is eccentric calcium at the circ origin, and there is this 360-degree calcium as well at the diagonal origin that was seen. And to measure based on this...
maybe, Mishita, maybe there's 1 second here, let it play, and then we can have... Ziad and Farouc, what do you guys think? I mean, looking at this, first of all, when you look at the composition as we're seeing here, do you typically put on the coloring to try to look at it on the black and white. I mean, how do you typically assess the calcium? And I know, Ziad, you're the creator of some of the scores of when to use advanced calcium modification techniques. So how would you analyze this, and how would you approach this particular form of calcium here?
Yeah, so that's a great question. And I actually start just as been doing here. And basically what you're looking for is the predictors for stent under expansion, which is a calcium arc of greater than 180 degrees, really currently 3/4 of the vessel or 270 degrees. Thickness that's more than 0.3 millimeters. We can talk about what the energy detector CT will overestimate that in just a moment. And then, of course, the length of 3 millimeters. And so what you can see in this view is you can see that most of this calcium is eccentric, just like was shown in the previous, I think, more difficult to understand assessment. This is where I really like heart flow. You see a completely normal landing zone. And what I like to do here is actually turn on the lumen wall and the outer wall selections up at the top. And by turning those lumen wall and outer wall at the top, it'll show you where your good landing zones are. Because if you have the lumen and outer wall close together, that's a perfect landing zone. Now, the other thing that that's really important here is, remember, the AI here works on a threshold. And so once it crosses 400 Hounsfield units, it's going to call all the calcium the same. We know that's not the case. So you got to turn the calcified blue coloring off and actually look at the calcium and look at the density.
Perfect. Thanks, Ziad. Again, great way to look at it, and you need to look at both of them. And there's obviously the MIP as well that you saw earlier on, and they can also give you kind of the 3D reconstruction of the calcium. When you decide, you said about the criteria of the circumference, the thickness, the length. Farouc, do you do anything different when you look at calcium, or you just follow the same guidelines, circumference, thickness, and length of the calcified segment?
Those parameters have been, the most studied in part from Ziad, and I think those are very, very helpful, very practical. I think I tend to be direct image oriented, and I love grayscale images. Your eye is just far more likely to see the various details of heterogeneity. And one of the points mentioned is the intensity of calcium. The hardness of calcium is really, you don't necessarily want to binarize. I think we're learning more and more that there is going to be very resistant calcium to certain devices, and Hounsfield units are greater than 1,000, for example. So I think that's, this approach is really great. What's lovely about it is that it doesn't take very long to do this, right? And it's really automated very quickly. And that initial assessment right at the diagonal helps one understand that, wow, we really might be in a calcium modification planning phase. And that's great to know, rather than going in blind.
Wonderful. Thank you. Thanks so much, Farouc. Mishita, go ahead. Sorry for the interruption.
No, thank you, everyone. Those are great points, and that's exactly what we thought. But here, just to mention about the healthy landing zones that we had planned. The proximal was 2 mm from the ostia, and the distal, I just took a click here. It was 56 mm from the ostia, which looked pretty healthy. So our length was 54 mm that we had planned to cover, and this is the same what we had gotten from Vitria as well. And this was the calcium that I just wanted to point out, which really made us think that we would be dealing with a lot of calcium here and would need some calcium modification. And we planned to go upfront with intravascular lithotripsy. This is the heart flow roadmap also that they provide, where also, as it can be seen, that is a very calcified lesion. We see calcium at the origin of the circumflex. It looks like an eccentric calcific nodule, and there is some calcium here at the diagonal origin as well. So this was the FFR-CT analysis. Could not be done across the RCA because there was a pre-existing stent there. Across the circumflex, it was actually negative 0.89. And this is across the LAD, as can be seen here. It's like a FFR pullback, where we see the most of the drop occurs across this diagonal lesion. And then I wanted to include the virtual PCI planning that we had done as well. However, I learned, like, because of the amount of CTs we do, there is a good turnover, and I didn't have the virtual PCI planner for this particular patient. So I just included an example. And for this particular patient, when we tried to cover from left main to LAD, distal to the diagonal branch, then the FFR value that I had gotten was 0.93, and when I just tried to cover across the diagonal branch, not extending to the left main, in that case the FFR was still 0.89. So we planned upfront to go from healthy to healthy landing zone from left main to LAD, distal to the diagonal branch. Morphology. So CT pretty much helped us pre-planning our PCI, where we already understood the morphology that we are going to be dealing with a lot of calcium. We'll need to cover a length of 54 millimeters. The distal reference that we got from CT was about 2 by 2.2. The catheters, because the aortic root measured 3.3, so EBU 3.5 guide catheter, and we plan to go upfront with 7 French catheter because of the bifurcation lesion and calcium modification that we were anticipating, and diagnostic JR 5. So this was our planning. So took first the angios with the JR5 catheter, and we see there is actually moderate disease in proximal and mid RCA. And then went with the EBU guide because we already knew the anatomy, and we were planning for LAD PCI, so went further. But however, there was tortuosity that was difficult to navigate with the EBU, so ended up using a catheter-assisted tracking with the longer multipurpose catheter, and was able to cross. And then these are the left coronary angio images. As can be seen, the left main, it looks good. There is some disease at the ostial left circumflex. And here, just you can see there is diffuse LAD disease, and there is the eleocrene view as well that will show the ostium of the diagonal branch better. So our plan was for provisional stenting across the diagonal branch, and we wired the LAD first, and then using the dual lumen microcatheter wired the diagonal branch. And then for the circumflex, because there was some ostial circumflex disease, we ended up wiring it with a pressure wire and measured the DPR of 0.98 before we did anything. And then we wanted to do the IVUS across the LAD, but there was difficulty passing the IVUS, so had to sacrifice the diagonal wire. And after that, on the IVUS, as you can see, this is the IVUS pullback, and we will see there is this eccentric calcific nodule that we see here. There is the branch here, and then this is the calcific nodule again, and we'll start to see our circ wire coming here, and this is, we are in the left main now, and there is some plaque in the left main, but nothing crazy there. So since we already knew the anatomy and the calcium,
so I'm sorry, Mr. Maybe 1 second. So based on what you've seen right now on the CT and on the intravascular imaging, Ziad, would you have done anything different in terms of preparation? It looks is mainly eccentric, as you said before, on the CT and also on the IVUS. Would you have done anything different, or you agree with the current plan of preparation?
I would have probably just started with a non-compliant balloon here. The main reason is that the concentric calcification was very short. And so short concentric calcium almost always breaks with a non-compliant balloon, especially when it's not excessively thick. And if you go back on the CT, we didn't talk about this, but basically energy detector CT overestimates your calcium thickness by 60%. So if you basically reduce your minimum thickness by 60%, that's how thin your calcium is on energy detector CT compared to OCT. So I think an NC balloon would have broke this. I think, given the amount of calcium, it's not, of course, not wrong to use IVL, but you probably would have gained significant and sufficient fractures with a non-compliant balloon here.
Wonderful. Farouc, anything different that you might have done in this particular case?
Yes, I saw 3 wires there. Did I understand that the IVUS was not possible doing the diagonal, and you actually had to deliver the IVUS down the LED by pulling the diagonal wire?
Yes, Dr. Farouc.
Yeah, why was that?
So I don't know if there was like a wire wrap that was happening, or if it was just like we had 7 French access, so I would have expected, but we ended up sacrificing the diagonal wire, and after that the IVUS went straight up. But I think it was likely the wire wrap that could have occurred.
Okay.
The vessel.
Did you have a chance to have a sense of whether that diagonal would be compromised at baseline, what the physiology was from CT? I'm sorry if I missed that point, but is this, obviously a branch to protect? And what was your thinking about beyond the diagonal itself? Was this severe enough to warrant a 2-stent strategy because it's a large diagonal? How did you actually know that it should be provisional?
Yes, so based on the CT, there was mild disease in the diagonal branch. So that's why we did not think that it would be compromised, but we still wanted to protect it and at least have a wire there. But like we still plan on to doing just a provisional strategy, and did not think we needed to go for 2-stent strategy there, given the amount of disease that was there, just mild in the diagonal branch.
Totally fair. I think when I see concentric calcium and think about a large plaque burden at that bifurcation, then one could be prepared to be ready for a rescue. And that's also helpful to know up front where that concentric calcium is on CT going in.
Wonderful. Perfect. So, Mr. if you want to finish the case.
Yes. So here, so we went with the 2.5 IVL to mid LAD, and then we did do a non-compliant balloon to the proximal LAD and left main, and then did IVUS, but the calcific nodule, the eccentric nodule that we saw on the IVUS, that was still not prepped well. So we ended up going with the 3.5 IVL to the prox LAD. And you'll see here, like even after all the pulses were delivered to the prox LAD, there was still some waste that we saw. So we had to do further calcium modification with angiosculpt balloon and non-compliant balloon. And after we were happy with our results on IVUS, then we ended up deploying a 2.5 by 30 millimeter drug-eluting stent to mid-LAD with an overlapping 3.5 by 24 megatron to left main to prox LAD. And using the stent balloon, we post-dilated the mid-LAD stent, and then used another 4.0 by 6 NC to post-dilate the distal left main prox LAD stent. And this was the final outcome.
Yeah, beautiful result. And looks like there's some LAD bridging, right? So you were careful not to stand over that bridge. That can be a first of all, the stent may fracture, but also you can have high restenosis rates regardless. So that was a great adjustment of the stent.
Yes, and since we had the FFR wire already in the circumflex, we ended up doing a post-PCI FFR as well across that circumflex after we stented across there, and it was 0.91. And the post-PCI FFR of the LAD was 0.93. And as you saw here, our diagonal branch was still with us, thankfully. So this was the case. So the key learnings from this case was that the CT-guided PCI optimized the guide catheter selection and precise physiology-driven revascularization with excellent outcomes. It provides a sizing reference, and in our experience, we have often required to upsize by 0.25 or 0.5 to optimize stent selection and expansion, and assessment of bifurcation anatomy to plan bifurcation PCI, and identification of calcification prompting upfront calcium modification, and CT-based virtual PCI FFR helped identify functionally appropriate and healthy landing zones. Thank you.
Yeah, thanks, Ms. Ziad. Excellent case. One question that came from the audience is, to what extent should guide catheter selection be determined by CT-derived signs of Valsalva dimensions and coronary ostial height, etc.? And do you modify it based on radial or femoral? So maybe Ziad, do you typically use the the axials, as Misita showed, to choose your guides? And does it matter if it's radial or femoral?
Yeah, I don't think it matters. We typically just make a simple measurement, and usually it's a good gestalt in terms of picking what guide we have. I think overall, in simplification wise, it tells you, do you have a big root, small root, and then obviously we don't have 4.2 millimeter guides, so you adjust based on your, is it going to be 4.5 centimeters versus 4.2? So you're going to pick our 4 or 4.5. So generally, off the axials, we're just making a sort of general estimate of how big the aortic root is.
Wonderful. And then there's another question from the audience about why the CT underestimates the vessel size.
So that's an important question and has a relatively complex answer. And so first of all, you can have an up to 40% change in the vessel diameter based simply on the use of nitroglycerin. So you can have a huge vasodilator capacity. So if you have the same patient who has nitroglycerin given and that doesn't have it given, you can have a 40% difference. The next thing is the scanner type, right? And you're basically how much kV are you giving? So at 140 versus 100, you're going to get a different measurement. So what we learned about sizing here, which is important, is that if you use the largest luminal diameter at your reference, both proximal and distally, you can very safely upsize for up to the next device size up on your distal reference and up to 0.5 millimeter up on your proximal reference. So that's how we've kind of done a lumen and up versus an EL and down for intravascular imaging.
Wonderful. And then another question that came, and then we'll go to the next case, which is about preferring IVUS or OCT in calcification. OCT has the penetration, IVUS does not. But Farouc, any thoughts on this? Do you typically use either or? And CTOs obviously use IVUS for most of them, but if there's not a CTO, how do you choose the imaging modality for calcium?
Sure, I think OCT is superior. It's really a matter of, if you're going to pull it out in the case, you're going to be very happy with your calcium assessment from that because of the ability to resolve depth. And it's just higher resolution. So I think for surface-based assessments where you really need to know thickness, it's great to have it. I think that's, really the choice between the two depends, I think, on the complexity of what one is doing, how many runs one expects, how many vessels, bifurcations, et cetera. Certainly in CTO subintimal spaces, that's a different question. But I think it's great. But I also think IVUS is incredibly helpful. Well, it doesn't tell you depth. It's so incredibly sensitive for acoustic shadowing. It's very easy for people to start to see that and make appropriate modification steps and still get 2 out of the 3 Q criteria that Ziad and others have identified.
Wonderful. Thank you. Thanks very much, Farouc. And then thanks again, Misita. Appreciate it. And then we'll go to Dr. Samir. Dr. Samir, if you want to share your screen and go on your presentation.
Thank you, Professor Brilakis, Dr. Farouc, and Dr. Ziad. I'm really privileged to be among this webinar. So my case is finding the fugitive RCA. I have no disclosures. My patient is a 52 years male patient, smoker, hypertensive, pre-diabetic. He essentially presented with an anterior STEMI with a stuttering presentation. As protocol, we usually in our facility go first for a quick diagnostic for the non-culprit coronary system to proceed directly with a guiding to the culprit. However, in this case, the standard manipulations could not engage the RCA. We opt for cuspal injections in LAO and in lateral, but I could not find the RCA. So without further ado, we left over the RCA and went directly with an EBU. We found that the culprit lesion was mid-LAD around the diagonal bifurcation. Wired, for instances, we thought that it will be a smooth thrombotic lesion, but when we opted for direct stenting, it seemed to have a constricting stenosis that was luckily optimized with a non-compliant balloon, and that was the final for the LAD. However, with this final image, we realized that the RCA is filling retrogradely at the bottom of the screen. So probably we are dealing with a CTO RCA that we do not exactly know where it originates from. Again, with the EBO, for having the larger inner lumen, we went to the lateral view. We hugged the anterior wall of the aorta, the posterior wall of the aorta, tried our best at different levels to seek if the RCA could be visualized, but it could not. So to find that fugitive, we opt for CT next morning. And we found that the RCA has a superior inclined ostium that originates just above the sinotubular junction. And more of challenging that it has kind of a slit-like ostium that originates from the aorta at that site. Got sharply angulated with a hypoplastic, very proximal part outside the ostium. And as well, we have realized from the CT that there are kind of two levels of CTO. Then the RCA fits distally with little information that could be gathered about the distality of the RCA. But first of all, there was minimal calcifications along its course. And in the very mid RCA, the late mid RCA before it bifurcates, it was in the range of 2.4, 2.5 millimeters diameter with a sizable PDA and a sizable RV branch that were detected.
And then maybe stop there for a second. So in these cases, Ziad, when you have this, you cannot engage the RCA. I mean, here you have the luxury to get the CT. What do you do otherwise? And if you get the CT, how do you choose your guide then for the anomalous storage?
Yeah, so first of all, I think this is a very, very good way to identify exactly where your patient's anatomy, what your patient's anatomy looks like, especially when you're struggling. I think it makes prudent sense to, instead of using your 60 mils of dye, helicoptering in the aorta, take the patient off the table, get your CT. I think the next thing here is to make your measurements. And one of the nice things is, you know, some of the software, for example, the Pi Medical software actually lets you put in artificial guides to help you kind of manipulate this and help determine. But I think the key thing for me, Manos, I don't know of any software. I don't have any like a strict strategy of how I would do this. The key thing for me would be to know where I need to be in relation to other structures. And so, you know, this is telling you that you're sort of on the opposite side. You're very anterior. So probably, you know, I'm looking towards an AL guide that's going to face more anteriorly. And sometimes what you have to do is get in the vicinity of these and sort of airmail the wire, and it'll go into the coronary, and then you can use a guide extension catheter to get in.
Wonderful. Wonderful. Okay. Dr. Shamir, maybe you can continue.
Exactly. That's what we thought about. We thought with this anatomy that the amplets will be our best guide to get into the RCA. Yes, as soon as we put the guiding, there was some pressure dampening about having a CTO. This would not make a big deal. And in the lateral view appeared the hypoplastic part of the proximal RCA, the two levels of CTO, and then it fades near the middle part without any antegrade opacification. We started with antegrade wire escalation, and it marched smoothly through the middle part. However, when we get into the distal part of the RCA, the branching pattern became very, very challenging. Because the wire was oscillating in a very awkward pattern. But with several injections, unfortunately, at this segment, the retrograde injections did not opacify, did not give us what we needed of data. So we had to rely on the antegrade injections. And we needed to go for several views with advancing the wire until we knew where exactly would be the PDA among these branches. And finally, we could track into the PDA and advance it. Advanced the micro catheter with that thing and put a sine wire into the PDA, prepped the vessel, dilated, and gave our injections. What we have here is the shallow right caudal. This gives us very clear and beautiful expansion fanning of the branches. And what we have, like exactly what the CT showed, that the marginal branch, the RV branch, was much larger of a diameter than the BDA was. So we protected it with a looped field that we started with. And we opt to stent before the trifurcation, as a matter of fact, of the RCA, because distal to that, none of the daughter vessels could hold a 2.75 stent or a 2.5 stent even. These were two overlapping stents, 275/34 and a 326. Then post-dilated and flared the ostium with that final result. So we started with that RCA, and we ended with that, yes, smallish vessel, but apparently a deserving vessel with very acceptable and satisfying myocardial blush.
Wonderful.
And the fugitive was found.
Wonderful.
My key learning points that although interesting in drama, the fugitives can be really challenging in coronary work. Coronary CT is invaluable to identify ambiguities in coronary anatomy, saving contrast and radiation compared to attempting just to shoot in the dark with conventional CAG to find your anomalous or undetectable vessel. And with CTCA data, complex procedures should not be a trial and error. It offers the guidance for appropriate strategy, maximizing success. Thank you.
Wonderful, wonderful, perfect, excellent case and great catch. And also some of the basic techniques as well, having the dual guides. I mean, all these things are important before you put your stents and put your guide wires. Farouc, any thoughts on this particular case? Anything you have done, would you have done different in this kind of anomalous origin, right, coronary CTO?
Well, it just illustrates how incredibly valuable CT was in this case and what a difference it made in this patient's life, obviously, to be able to offer complete revas to a young person with a STEMI. Certainly some interesting things. When you see a slit-like ostium on CT, those are questions that will definitely be raised about surgical and roofing, depending on where the ostium is. And so depending on where the actual slit is. I didn't really appreciate the slit as well in angiography. Was that something in other views that you saw? And was there a consideration about surgical and roofing, which is, of course, a much bigger deal? He's kind of self-selected, being older, hasn't had a prior history of syncope or sudden death. So sometimes these are, just medically managed, but I agree with complete revasc in this case. But what was the slit-like part kind of further assessed?
Actually, in retrospect, I believe that the impression of a slit-like was due to the disease of the RCA from the very originating part with the sharp angulation. But when we put the amplets, it did not look like a very considerable slit-like. And also, we ensured to get a stent in the proximal RCA with a good radial strength, a good force, and to optimize it and flare it and it appropriately.
Wonderful. Great. And then Farouc, you do use the co-registration, right? You have the co-registration system. So Dr. Jaffer used the co-registration with CT and the fluoroscopy, and that would have been very useful here. Farouc, you have the most experience on this than anyone in the world. How would you approach this case? Would you have done the co-registration, and that might have helped with wiring, especially this distal RCA PDA bifurcations?
Yeah, thanks, Manos. That is one of my favorite things to do, is to facilitate blind wiring. When we cannot get the retrograde collateral contrast into the area of, especially a complex trifurcation, having the distal roadmap there for you, like you have it on your 3D MIPS and so forth, it's very, very helpful. And even if it's not co-registered in real time, understanding some of the angles, you can ask your CT lab to print out an LAO cranial for you and then you can kind of understand where those branches might lie. But absolutely, it is very, very helpful in a case like this to have had that. It really does make it particularly helpful if one is subintimal. You had the luxury of crossing true lumen here, so you could inject contrast. Could have taken a dual lumen catheter, wired other branches, injected down the dual lumen catheter without a fear of propagating hematoma. But there are some cases where you're not going to be able to inject. So then that roadmap can be particularly helpful in those cases.
Wonderful. Ziad, any other thoughts on this case?
This was a wonderful case where CT really significantly helped the patient, like Farouc mentioned. So I think when you use the technology to change the patient's outlook and the procedural success, I think that's exactly the sweet spot of this technology. So I think it was an excellent example.
All right, and without further ado, go to the last but not least, Dr. Nick Williford. He's going to show the last case of the day. So Nick, thank you so much.
Thank you so much. Can you see my screen okay?
Yeah.
All right, so my title is Where's the Cap? And you will soon see that I had no idea. So our patient was a 65-year-old woman with a history of hypertension and dyslipidemia who had a recent diagnosis of coronary disease when she suffered an RCA STEMI. She underwent successful PCI at that time, but was also noted to have a CTO of the mid-LAD. Unfortunately, when we saw her in clinic, the images were not available to us, but there was a report that stated that she came back for an attempted CTO PCI of the LAD, which was unsuccessful and was aborted. So we obtained our own angiogram. So these are our duals here. And I think I'll take a pause here and ask the panel where they think the proximal cap is.
No one wants to take it. You know, it's a tricky one. And
I think, traditionally what we would think is, CTOs often occur at the bifurcation. So right where that diagonal branch is, what I would be doing here is putting a wire into that diagonal and using IVUS and then doing an IVUS guided cap puncture to help me identify the cap.
I think that is definitely the number one thought. I have also seen this variation where that what I think is going to come off of that diagonal bifurcation is actually coming into what I was initially calling a septal, but it's actually part of the LAD itself. And so sometimes if just look at that, if it's possible to ultimately IVUS down that septal also, sometimes I've seen origins a few millimeters down. But it is really important because one, can start to be tempted to take in stiff wires, and one can be fooled. So I think the point that Ziad made, which is certainly you at least want to IVUS on that diagonal before one starts to actually poke at the actual split of that bifurcation. But I wouldn't be surprised, especially since we're presenting it here, that there might be an unsuspected course.
If you would allow me for a comment.
Sure.
I believe that the left main is kind of trifurcating, and there is a branch coming from underneath in between the both. And this is giving a septal
right here.
And this is in the direct continuation to the target vessel. While the dance is completely different from the bifurcation that we initially would think of. This is a totally different dance from the target vessel.
Great, thank you. So I thought it was this up here myself personally. And we actually, since we didn't have her angiogram at our original clinic visit, obtained a coronary CT, which gave us some really good information. And then I had reviewed it in clinic. And so we knew that the cap was blunt. The CTO was about 25 millimeters. The distal vessel was diffusely diseased, and that there were septals feeding it from the RCA. So before we even had an angiogram, based on the CT, our initial thoughts were that our strategy would be antegrade wiring followed by a retrograde approach. So as I said, I interpreted the proximal cap to be that stump that we saw on previous images. So we took a microcatheter and some wires, and we seemed to be getting into various branches that we thought were septals or diagonal branches, but we never really got anywhere that appeared to be in the direction of the LAD. So since we thought that we were in a septal, we brought down a dual lumen microcatheter, and again attempted to wire in the direction of the LAD, but you can see here that we didn't seem to be in the same plane, which made us a little uncomfortable. So we decided to switch to a retrograde approach. And while this looks quite elegant, it took quite a while. We went through many septals before eventually getting through our wire through one septal, and it appears to go down the distal LAD. We weren't able to get a Caravelle to cross, but we did get a fine cross M3 to cross the septal, and then tried to do a true lumen retrograde puncture with a Gaia. But at this point, we took a pause and actually did a contrast injection through the fine cross, and you'll see that there's a vessel here that looks eerily similar to this vessel here, as opposed to this stump that I thought was the proximal cap. So at this point, we had realized that we were probably not in the right place for our antegrade attempts. And so on the right, you see us again trying a retrograde true lumen puncture. And then we actually moved our antegrade equipment to the correct vessel at this point, and a workhorse wire actually seemed to go directly down the LAD, and our retrograde wires seemed to go into the proximal LAD. So we took an orthogonal view. Our wires appear to be overlapping. And then we redirected our retrograde wire, and I think it's difficult to argue that the wires seem to be in the same space at this point. So we ballooned, and this is our angiogram post-angioplasty. So you can very clearly see here that the location that I thought was the proximal cap was not at all the proximal cap. And it wasn't, the LAD was indeed coming off of that branch that we looked at initially. So we IVUSed the vessel. The distal vessel was small and diffusely diseased, and the proximal portion was large. So we deployed 225/38 and 30/15 stents. And then because of the diffuse distal disease, we used a 20/30 DCB on the distal LAD. And this is our final angiogram. And so, as I mentioned, we had actually obtained a CT that I had looked at in clinic, and then she came in for her procedure about a week later. And for whatever reason, I did not go back into the images to review her CT right before the procedure that day. I was very focused on the fact that we never received her outside angiogram, and so I was very focused on taking some quality angiograms. So this is the NPR, which doesn't necessarily tell us a whole lot in and of itself. However, we're fortunate to have AI software that has the CTO detection capabilities. And so when I show you the 3D reconstruction that our software made, you can see that the CTO has been detected where that red circle is in both images, which I think if you could put this next to the angiogram, looks almost identical. And you can actually even see that this small branch that I thought was a proximal cap is actually a ramus. So if I would have taken the time to look at this again immediately before the case, or scrubbed out after we took our initial angiograms to see exactly where things were, we maybe could have finished this case quite a bit sooner than what we did, and also not put wires in that small branch, not knowing exactly where they were. The other thing I'll point out is that I didn't show you this caudal shot in the beginning, and you can see in this view that this small branch that I thought was the proximal cap is also not necessarily in the area that you would expect an LAD. And again, on the CT view of at the same angle, you can see again that appears to be a small ramus. So my conclusions are, if you're going to do CTO PCI, You have to know your proximal cap ambiguity algorithm. And I would make the argument that CT should be number one in that algorithm. And most importantly, if you get a CT, you should look at it. So thank you very much.
Wonderful. Thank you. Thank you so much, Nick. And again, lots of learnings over here. Ziad or Farouc, any thoughts?
Well, I think the punchline was right. If you get a CT, you should look at it. Unfortunately, it hasn't traditionally been that easy to do that. I think all of the vendors are now learning that they need to cater to the interventionalists, and that trying to squeeze an extra few dollars out for an additional license is probably not a good idea. So now CTs are becoming more available for us to read and interpret. I can tell you that I read every single CT in the cath lab before I go to the cath lab if they have one. I think it's a waste not to do it, and just reading the report is not being an interventionalist. It's being a bad doctor. So absolutely, I think that's the takeaway from this is you have a lot of information available. You should use it. It also reminds you that you can be fooled by the angiogram because it's a 2D structure of a 3D structure. It's a 2D image of a 3D structure. So make sure we can make it as 3D as possible.
I think in the future, this is going to be simplified for us more and more. If you have those CPRs, 3D rotational grams, and it's just the first thing that pops up when you open up a CT, you're just going to immediately be tipped off to knowing like what the actual anatomy is. In this particular case, that ramus is deceptive because it's also acting like an S1. It's got septals, and so it's very easy to think that's part of the LAD. But this is why 3D imaging is really great. And soon it'll be very digestible. But sure, no, I think in hindsight, it was been great to have done it beforehand. But I think this is also the reality that it's hard to get at that information in the routine setting, and we're making great progress, I think, to making it more and more simplified. So we're going to have these up front.
Perfect. And I think to Ziad's, thanks, Farouc, to Ziad's point, a big part of this is the ease and the ease of accessing the images as well. And the nice thing with the online platforms is that you can actually get it from any computer, any place, without having to go on the PACS and start the software. I mean, it takes us usually like 2-3 minutes just to get in the software and get the cross sections to pull up. So another thing, the ease, as you said, the ease of implementation is critical to the application of this. But yes, CT can really help, and we do know that CT is important for clarifying proximal camp ambiguity, and this is another example of this. So maybe in a few seconds, maybe we're just waiting for Dr. Jaffer and Dr. Ali to decide on the winner. So it's tricky, and then in the meantime, also we'll add the attendees to vote for their favorite case. But again, they were all phenomenal cases and all very instructive. So we appreciate everyone who presented the cases today. Okay, so there is a little back and forth between Dr. Ali and Dr. Jaffer. No pressure. And then maybe, Kelly, if we can show up the attendee case, probably if we can find out what they say, but I guess in the meantime, we'll announce it. So again, while we're doing this, I want to thank everyone for participating today. I cannot myself vote for this because I have people from my institution, so I cannot. So I'm waiting for them to make up their mind. They're texting each other fairly ferociously. But in the meantime, again, I would like to thank everyone for participating. I would like to thank our sponsors again, Abbott, Boston, Cordis, and Medtronic for supporting this. And then in terms of the audience so far, I guess 41% voted for Ms. Sita Goel, but I think we the panelists decided for Dr. Ahmad Samir. So Dr. Samir, congratulations. That was a great case. Thank you so much, and our team will get in touch with you for your prize and for your attendance of CVI. So thanks again, everyone. Ziad and Farouc, thank you so much for making it very instructional. And again, look forward to seeing all of you. We do have a lot of CT education coming up, and look forward to having all of you. There's one before ACC, a course before ACC, and multiple other courses are coming online. So thank you so much, and have a wonderful night.